Healthcare workers were able to apologize for the incident and create a process to prevent a reoccurrence. When appropriate, patients were offered timely and fair compensation without having to go through legal action. That led to an unprecedented agreement last summer between Massachusetts Medical Society, the Massachusetts Bar Association, and the Massachusetts Association of Trial Lawyers. We all agreed on medical apology language that was eventually written into the state's sweeping healthcare reform bill signed in August. Interesting, what we are now calling the Communications, Apology, and Resolution Approach, nicknamed CARE, which I think is a better acronym than the other one, continues to grow. At the AMA Nationals Advocacy Conference, there were many of us from the Massachusetts Medical Society there. It was in Washington, D.C. in March. We shared the CARE approach with members of the Massachusetts congressional delegation, including the new U.S. Senator Elizabeth Warren, who is very interested in this project. We have much more work to do in educating our fellow physicians and our patients about the benefits of medical disclosure and resolution. The Alliance's effort these past years have placed Massachusetts at the forefront of medical liability reform, and we congratulate you. Now I'd like to hand the program over to Dr. Alan Woodward, who is a past president of the Medical Society, and from our perspective at the Medical Society, one of the greatest proponents of this project. Alan, would you like to take over?
Good morning. I want to welcome you here today, but also remind you that just 1 week ago, at this moment, this building, the city of Waltham, most of the Metro West area, and Boston were all in lockdown. The bombings at the marathon were an assault on our citizens, our traditions, and our sense of security and well-being. But the extraordinary response from all quarters has helped restore our faith and the healthcare system's ability to meet the needs of the nearly 200 injured, many critically, has gained accolades from around the world. For not a single patient succumbed that was not killed in the initial blast, despite innumerable horrific wounds. This is a remarkable testament to our EMS system, to our hospitals, and all those that provided care, as well as to our commitment in this state to healthcare planning and emergency preparedness, also at the regional, local, and institutional levels. So as our thoughts are with the hundreds of direct victims and the innumerable indirect victims of this incomprehensible act of ruthless inhumanity, let us commit ourselves and our efforts here today to further improve the safety and humanity of our healthcare system to best meet the needs of our patients and the citizens of our Commonwealth. Thank you. So I'm really here to talk to you about the efforts we're making to transform the medical liability system in Massachusetts. And my role is to give you some of the background and talk about the accomplishments in the implementation phase over the last 12 to 18 months, and then some really current information on efforts we're making. And then you can see from your agenda, we'll go through a sequence of presentations and then open up for about 45 minutes of questions prior to the lunch hour. So starting with background, we had pursued tort reform in Massachusetts when I was president in '05, but felt that ultimately tort reform was not going to address all of the failings of the current system, which I'll articulate. So we started looking for alternatives to classic tort reform and established a task force here to look at the alternatives. We selected disclosure, apology, and offer as the best alternative and looked at the evidence and advantages of same. Then once we had determined where we wanted to get to as an endpoint, we sought a ARC planning grant to develop a roadmap for Massachusetts to move us forward. So starting with the failings of the current system, and I will point out that most of these can't be addressed, or many of them, by classic tort reform. First of all, for patients, we know that the system is unfair and that a small minority of avoidably injured patients are compensated. The average time to an award through our court system is 5.5 years. We know jury awards vary by 40-fold for similar fact patterns. We know that patients get less than a third of what physicians pay in premiums for medical liability. We also know it's very isolating for patients when there's an adverse event. And in this current system, patients rarely get an apology. And you're going to hear more about that, and we know that that's a critical shortcoming. For physicians, particularly in high-risk specialties, premiums are extremely burdensome. Physicians and all practitioners live with a stress that they can never make a single bad decision, or it can have tremendous impact on their psychic and professional well-being. We know that when practitioners are sued, that their depression rate, their divorce rate, their suicide rate, their sudden death rates, and their myocardial infarction rates all go up in a statistically significant fashion. We know that from our workforce study that practitioners are modifying practice, avoiding high-risk patients and avoiding high-risk procedures as a result of the liability system, and that this liability system motivates physicians to practice defensive medicine. So if you look at the healthcare system as a whole, the current system compromises patient safety. It compromises the distribution and well-being of our workforce, and subsequently access to care. And it drives practitioners to practice defensive medicine, which drives up healthcare costs and compromises the ability to insure or fully insure our population. So what we said as we got into the discussion of bending this healthcare cost curve, and you can see that in Massachusetts, as is true in all states and across the country, that the per capita healthcare expenditures are rising 2 to 3 times as fast as either per capita GDP, wages and salaries, or consumer price index. So what we've said, if you're going to get serious about healthcare costs, you need to address the drivers of overuse of resources. And if you view at the peak there that that's optimalist care, what I will call optimalist care, the highest quality at a moderate cost, we need to look at all of those that are forcing physicians or motivating physicians to practice what I will call maximalist care there on the right. And we think that defensive medicine, from our own study and multiple other studies, is one of the major drivers of excess use of resources. And you can see there are many others, and you can add to that list. But there are multiple studies of defensive medicine that have suggested it's as high as 20 or 25%, or suggested it's as low as 2%. But that study actually looked at the impact of comprehensive tort reform. And comprehensive tort reform, although it mitigates the rate of rise of premiums, does not address the fundamental fear issue which drives defensive medicine. So what we've said is if we're going to get serious about healthcare costs, we need to deal with a system which is driving defensive medicine. The result, our conclusion, was that, as Lucian has articulately said, the current system is an impediment to patient safety improvement, as Michelle has said, for competence, deterrence, corrective justice, etc. For all criteria, the current system gets lower failing grades. And our conclusion is that the current system is unduly onerous for patients and providers and undermines our healthcare system as a whole. So when we looked at the alternatives for reform, nobody wants to deny people access to the tort system, but can't there be an approach that's available prior to getting into litigation? A system that is fair and efficient and reliable and just and accountable, and supports patient safety improvement and reduces the fear that drives defensive medicine. So when we considered the alternatives, and again, we had a task force, but also I happened to be involved in a commission that was a roundtable that was convened in Chicago by the Joint Commission, and it brought together patients and patient advocates and patient safety experts and insurers and defense and plaintiff attorneys. And there were about 35 of us, and we had multiple meetings, but at the end of the first meeting, we said, we don't just want tort reform. If we're going to deal with the patient safety side of this equation, we need to look at an alternative. We came up with 20-plus recommendations, did a press release in Washington, and you can pick up this document on the Joint Commission website if you wish. But one of the options that became, to me, to have clear advantages was disclosure, apology, and offer. And as Dick started to mention, what is entailed in having a disclosure and apology and offer model is that you implement a baseline culture of safety at every healthcare enterprise. capable of doing a thorough analysis when there's an adverse outcome, and implementing changes and improvements to prevent a recurrence. That the findings of that process should be disclosed to the patient and the impact on their health, and what you're doing to prevent recurrence. If it's an avoidable injury, there should be an appropriate and sincere apology, and if warranted, timely and fair compensation without having to resort to litigation. And if you disagree on the amount of compensation, that should go to mediation or a form of alternative dispute resolution, so that most of these cases should and can be resolved before you resort to the tort system. The principles as articulated by Rick Boothman are fairly straightforward. To compensate patients quickly and fairly when unreasonable care causes injuries, but if the care is reasonable or did not adversely affect the clinical outcome, then you support the caregivers and the organization vigorously. So this is not no-fault insurance, but you should learn from every adverse event and the focus should be on reducing recurrences and patient injuries. The evidence when we looked at it in making our decision in 2007 was really limited pretty much to the University of Michigan. For Rick, who you're going to hear from earlier, had started this in 2001. That year they had 262 new claims and more than 300 open cases. 6 years later, they had 73 new claims. Last year, he tells me it was 63, and less than 80 open cases. The average case resolution time dropped 60%. The cost of managing each case dropped 60%. They stopped buying reinsurance. They reduced their reserves from $72 million to under $20 million, and they put those funds back, rather than just reducing premiums for physicians, they put that money back into patient safety improvement efforts to further reduce the number of new incidents. Their court cases have been reduced by more than 90%. Rick now tells me they're litigating on average, less than one case per year. And they provide for their practitioners unlimited coverage, not 1 million, 2 million, 3, 5, or 3, 6, 5, 10, but unlimited coverage with lower premiums. But the proof that the people working in this environment are comfortable with this as a just culture and a means to improve patient safety is their incident reporting had gone from about 2,000 a year to about 20,000 a year. And it has changed the culture and reduced the fear. And when I was out there this past November, meeting as they do every month with their medical liability review committee, one of the OBs told me, we no longer teach our residents how to practice defensive medicine. We teach them an entirely different model, how to focus on safe medicine. So what we're talking about here is a fundamental transformation of the system, and we think it has multiple advantages. Our current system, as we know, is very reactive. It's very adversarial. It's the wall of silence. It's the culture of secrecy. People tend to deny and minimize their participation often in finding root causes. The systems tend to blame individuals. Both patients and providers are isolated when something goes wrong, and it's a fear-based system which drives defensive medicine. And really what we're talking about now is a proactive approach where doctors and nurses and others identify problems, advocate for patients when something goes wrong, where there's full disclosure and transparency for the patients. And most importantly, are one of the major components, that there's apology. And we know from Aaron Lazar's book and others that apology is therapeutic for both sides. For providers, it helps them deal with the grief, and for patients, it helps them deal with the anger and get over the anger so they can move on. But the focus, instead of blaming individuals, becomes the just culture and focusing on system repair to prevent recurrence. And instead of isolating both patients and providers, as the current system does, and I'd advocate that you all read the article, Guilty, Afraid, and Alone, which is on our website by Sigal Bell and Tom Del Banco. It provides supportive assistance to all of the victims and maintains the trust between providers and patients, and allows then for providers to feel comfortable practicing evidence-based medicine.